Respected judges and dear colleagues, very good morning. I'm Dr. Javaid Ahmad Bhat. I'm going to present a study on the effects of vitamin D supplementation on metabolic and endocrine abnormalities in PCOS patients. As we know, PCOS is the most common endocrinopathy in women at a reproductive age group. Prevalence varies from 4 to 18% and manifests as hyperandrogenism, ovulatory dysfunction, and polycystic ovaries. And it has been associated with a broad spectrum of metabolic and endocrine abnormalities, leading to higher risk of developing cardiovascular disease and diabetes mellitus in adult life. There is a pandemic of vitamin D deficiency going on. So is the case with the polycystic PCOS patients. And these has been found to have higher levels of vitamin D deficiency compared to the general population. And this vitamin D deficiency has been associated with the insulin resistance, hyperandrogenism, ovulatory dysfunction, and infertility in them. Vitamin D, though there are not many studies on the supplementation of vitamin D in these patients and their effects on the metabolic and hormonal profiles, we aim to study the impact of vitamin D supplementation on clinical, hormonal, and metabolic profile of vitamin D deficient insufficient PCOS women. Ours was a case-controlled study involving vitamin D deficient females with the level of less than 30 nanograms per ml of age 18 to 40 years, diagnosed on the basis of Rotterdam criteria. We had 48 patients at the beginning, were randomly divided into two groups. Group A included 23 females and Group B 25. Group A received metformin 1 gram and vitamin D 4,000 international units daily, while the Group B was given metformin and placebo. Follow-up was done at 2 months, 4 months, and 6 months. At the final analysis, we had 20 patients in the Group A, that was the supplemented group, and 21 patients in the placebo group. At the baseline, there was no significant difference between the parameters like age, BMI, menstrual irregularity, FG score, or for that matter, testosterone, fasting glucose, fasting insulin, or cholesterol, or other lipid parameters. At the baseline, we had the 33% of these PCOS females who had vitamin D insufficiency, and rest of the patients were having vitamin D deficiency. There was no significant difference at the baseline between the two groups as far as the vitamin D concentration was concerned. However, post-supplementation at 24 weeks, there was significant difference between the vitamin D levels in the Group A, the supplemented group, and the Group B. And moreover, we had achieved 100% in 100% of the PCOS patients level of more than 30 in supplemented group. There was a significant difference of testosterone level, lipid parameters in cholesterol and TG, and fasting glucose level in Group B as Group A compared to the baseline after supplementation. However, there was no such difference in the Group B. At 24 weeks, phenotypic parameters like BMI, hirsutism score, acne grade, there was no difference, as was with the menstrual irregularity and ovarian volume in both groups compared to the baseline. However, there was a decrease in the fasting insulin levels, HOMA-IR, in both groups compared to baseline, which was more significant in Group A. So comparing the Group B with the A, as compared to Group B, there was the significant decrease in the testosterone level, fasting glucose, as was the improvement in the fasting insulin, HOMA-IR, and Matsuda index post-supplementation. The limitations of our study was a single central study, variability of vitamin D levels according to season and region, and moreover, a small follow-up period. Our data showed that vitamin D deficiency is prevalent in PCOS patients in the Kashmir Valley. Addition of vitamin D to metformin improved insulin resistance, hyperandrogenism, as well as the lipid parameters, fasting insulin levels, glucose homeostasis. However, there was no improvement in the phenotypic aspects like acne, hirsutism score, or for that matter, menstrual cycle irregularities. Therefore, vitamin D supplementation in patients of PCOS on standard treatment should be thought of and given. Thank you.
What is the prevalence of vitamin D deficiency in the general population?
Sir, it's around 60 to 70%.
So it's not different from what you see in this.
Yes, sir, it's not different. But studies have shown that in case of PCOS females, it's slightly more than the general population.
But you said 67% here and 60 to 67%
yes,
in the
yes,
non-PCOS
case,
group
yes,
also. So not much difference.
Not much difference.
And this kind of improvement in the insulin resistance could be seen even in the other group.
Yeah, but significant it achieved significance in this group where we supplemented the
Yeah, what I mean to say is, even in the general population, if you supplement with vitamin D, there may be some improvement in the insulin
Yes,
resistance. PCOS may not be peculiar for
Sir,
this
since
kind
we
of
have taken the
improvement.
PCOS cohort, so
There is no difference in the phenotypical
Yes, sir, there was
improvement
no
with vitamin D.
Well done study, but I have two questions. How did you randomize, and what was your method of making this placebo? You said it is a...
Yes, randomization was done. It was every alternate patient was assigned to different groups.
so once the patient came in,
yes,
first patient went to vitamin
went
D.
to one group, second went to
So it was
every
just
yes, consecutive patient was assigned
so,
to.
but it was not blinded at all.
No, sir.
So you will know that the next patient is going to
Yes,
vitamin
sir.
D.
We were
So it was not really blinded.
not blinded.
Then how did you make a placebo? Was the patient blinded to the fact that they were getting...
It was patient blinded.
No. How did you create this placebo? Who made it for you?
So actually, Mayer Pharmaceuticals, they
So
gave
they
us-
made this placebo
Yes,
for
sir.
you with vitamin D.
Yes, sir.
But you were not blinded, the patient was blinded.
Patient was blind. We were not.
You were not
We
blinded.
were
So
not.
would you think that would have had an impact, because you are the person who's assessing?
Actually, sir, every alternate patient was assigned.
No, but still
So-
you know that this
Yes, sir,
patient
we
is on
were-
vitamin D, and
Yes.
you are already inclined to believe vitamin D is going to improve things.
Yes. Sir.
So then that would spoil your results a little bit,
Results.
because there might be a little bit of bias there.
Yes.
Could have made it much better if you had blinded yourself.
Yes.
You've chosen to give 4,000 daily.
Yes, sir.
So if you want to translate that thing in a daily practice, then sometimes the convenience is better with weekly or monthly doses.
Yes, sir.
And you could have a third arm where you can give this kind of a dose.
Yes, sir. Actually, there was a study earlier on which was done again at our center where 60,000 international units were given compared to this 4,000. There was not much that difference as far as the vitamin D sufficiency was concerned at the end of the 6 months. So we have not included that in this study.
Overall number is small also, so you can't make 3 groups probably. Even for the 2 groups, you have 20-25 people only.
Can you tell what is allocation concealment? Have you heard of that term?
Everyone?
Allocation concealment.
No.
No, he
So
was not
Doctor-
concealed, because he knew next patient will be on vitamin
No,
D.
I'm just, that's what Dr. Jubin was asking you. So that's when you don't know the patient is going to randomized into which arm.
Yes.
Otherwise, there's an element of selection bias that will creep into it. May not even be conscious, but you will put the wrong patient, I mean, according to the right patient in the right group you will
Yeah.
be putting, and that will influence your results.
If
Thank
you
you.
had done
Thank
that, it would have been a very good study.
Thank you.